Hello, I'm Dr. Frank Jarrell, and I'm presenting on the power of spinal reflex therapy in pain management. In today's world of pain med difficulties in this country and other pain-related management problems, pain has become front center in a lot of our strategies and therapies that we use to work with clients and patients. The power of spinal reflex therapy in pain management is going to be one of the most effective and efficient ways to manage pain in most of your clients and patients. So today, I'll start by emphasizing or speaking about who I am. I have 30 years in professional practice, 25 years teaching professionals on continuing education. Developed extensive pain management, therapeutic and diagnostic protocols, and designed the only evidence-based pain management technique for massage. I also have developed the only infrared pain and inflammation management technique, and we offer the only system that delivers like a master's degree in massage for the therapist in their practice. What does that mean? The objective with spinal reflex therapy is to provide skill sets and training on how to maximize your ability in treating your clients and arriving at the greatest, what's called objective functional improvement. SRT is like a master's degree in massage and pain management. One of the reasons we state that, and I'm going to go ahead and jump off and just continue to talk from a video point of view, but when we speak about spinal reflex therapy, it's a bit like a master's degree in massage and pain management. That is that this is a postgraduate approach. This is not helping to expand upon your basic massage training. We have made it effective and convenient, and we have made it easy to learn and to apply, but at the same time your response is going to be as if you've taken a huge leap in your own massage protocols and techniques and your capabilities. So with SRT, or spinal reflex therapy, we're going to teach you to learn to go beyond just the muscle and make the greater difference. Why? Because SRT acts through the muscles to trigger a deep healing phase. We're going to talk about how SRT takes you into that space where you can affect people's healing and accelerate that. It's a go-to technique for pain and functional management. It's also a way to locate the driver of most pain in as little as 1 to 2 minutes. It's also a system that lets you choose treatment sessions of 5, 10, 15, 30, 45, 60 minutes or increments according to what your client's needs are and their time constraints are. SRT also can drive every aspect of a successful practice. So we'll address these issues and many more in the following 60 minutes. First, I'm going to introduce you to my oldest client. He's a great example of how pain and management can be a very important option for clients and for their overall health and well-being. This person's very, very old and he's in much pain. Seriously complicated case. He's a tribute to what we can discover, and he's a confirmation as to how little we know. This is Frozen Fritz. Frozen Fritz is a male, 5 feet 5 inches tall, 134 pounds, age 5,362 years old. His favorite foods: chamoy, red deer, ibex meat, herb bread, legumes, roots, fruits, flax, poppy seeds, and berries. He enjoyed collecting copper, arsenic, whipworm, cavities, Buse lines, Lyme's disease, H. pylori bacteria, knee, ankle, and lumbar spine degenerative disc, and joint disease. He also experienced extensive spinal spondylosis, osteochondrosis, and he is lactose intolerant. Fashion statements: liked Italian shoes, goat leather leggings, various fur coats, belts, and has a man purse complete with drill, flint, chips, bone, antibiotic, fungi, and one snowshoe. He's a very forward thinker. His cutting-edge copper axe, flint knife, quivers, incomplete bow, and tattoos 2,000 years before the discovery of acupuncture in China. So if we look at Frozen Fritz as one of the oldest clients in the world, actually not mine, but if we look at him from a point of view of how much disease and injuries and problems did people have 5,000 years ago. He was actually found in the Italian Alps and on the Austrian-Italian border, and by some hikers, and he was found in ice, and they removed him over the following year. And through the science of forensic medicine, the findings on Frozen Fritz through MRIs and other lab values indicate that he had an extensive history from a health point of view and a disease and injury point of view. When we talk about what's called Lyme's disease, actually it's fascinating in that the Lyme's disease that he had genetically was from northern India. When he lived in an area in Italy, the Italian-Austrian Alps that was thousands of miles from India. It was also a place where they lived in groups of 50 to 60 people called tribes. And they would roam typically no more than 50 to 60 kilometers from their location. So hunter-gatherers, and so there's a lot of fascinating things about it. But the most fascinating is that the acupuncture tattoo marks on the arms and legs were consistent for most of this person's conditions and injuries, and appeared on this person 2,000 years before acupuncture arrived in China from a population that wasn't known to travel very far from their location. So the point of this particular client is to indicate that pain is not new to the human species. Pain has been with us for thousands of years. And this particular person had a lifetime of pain. Elbow, knee, low back, arm, leg, degenerative joint, intestinal, copper poisoning, dental caries, effects of cold climate, and inflammation. When we look at this and we say, okay, this particular patient, how does pain work in somebody of this particular character, this particular experience in life? We know that a number of pain receptors in the body measure mechanical pain, mechanical stress on tissue, mechanical damage. And some of them, like intestinal from bacteria, etc., are measuring chemical pain or overstretch of the organ. We also know that things like copper poisoning or other chemicals can cause pain through something called chemical pain receptors. Dental caries, bacteria, inflammation, chemical pain receptors. The effects of cold climate, extremes in temperature, can trigger pain receptors. Inflammation, which is one of the most fascinating, also triggers something called a silent pain receptor, one that you actually don't feel, but it talks to parts of your spinal cord and brain that don't actually relate to the primary pathways of pain that most of us are used to. They also tend to rewire the brain and the nervous system to actually increase your sensitivity to pain. We'll talk about that in a few minutes. Do we experience similar pain in America today? Americans consume 85% of the pain meds in the world, with only 4.5% of the world's population. You almost have to read that twice to get the gist of it. 85% of the pain meds in the entire world, and we only have 4.5% of the population. We spend over $1 trillion annually, and it's growing, and it's increasing every year, yet our outcomes are dropping. Excuse me one moment. This country is in the epidemic of a pain med overdose problem that is not shared by any other nation. Why do we hurt more than any other country in the world? That's a particular question to keep in mind as we go through and learn more about pain and how to manage pain. We also generate more pain to modern living problems, such as industrialized food in the environment and toxins that are inflammatory. More sources and causes of pain than we had 5,000 years ago. So today we have more conditions and situations that can cause us to experience more pain over a given lifetime. In order to manage pain, you must understand how it works on a functional level. Academic is one thing, and if we talk over this next 45 minutes, hour, that the academics of pain is extensive. However, the functional aspect of managing pain is what really becomes critical. That is how can you help your client in pain? And we'll call that functional care. That is, can we make a difference in the status of that person, the function of them, not just tick off how bright we are about understanding pain's academic component. So pain, if we start out from the very basic component or factors that comprise the purpose of having pain and painful experiences in the body, is that pain is an alarm, it's a signal, it's an opportunity for change. You change your relationship with your environment. It's to tell you that whatever you're doing, experiencing, or that is happening is causing damage to the system, and it's time to change, if possible. So pain is also a process. It's not an event. Pain, only the timeline and the severity of pain changes. However, the concept that pain is always an event is just simply based upon the timeline. If it happens very fast, then your body goes through processes that still let you know you're in pain, that let you know you damage the tissue, that let you know you have to change in a high-speed situation. However, pain can also occur over time, over months, years, over a lifetime, and become chronic conditions. So the timeline can vary, but in all cases, the experience of pain is a process. But when it happens very fast, it appears and feels as to be an event. So your client, your patient may explain it as an acute situation. Well, that can be anything from an immediate injury to it happened over 3 or 4 days to it happened over a month. And then we define it as acute. Well, we also talk about when it becomes chronic, which is typically more than 30, 45 days, then it becomes chronic. So think of it more as a process, not an event. Something called the periaqueductal gray, or the PAG, and it is your safe, natural, non-addictive pain control system. Everyone has it. If you have a brain, you have a PAG. So with a PAG, you have a system that actually produces pain medication, and not medication because it's not delivered to you, pain analgesic compounds that actually control your own pain. Two types of pain, fundamentally, if we look at it from a functional point of view, is fast and slow nerve conduction pathways, or pain. We call them fast and slow. Fast is the type of pain you experience when the dog bites you. Slow pain is the ache after the dog bites you. You stub your toe, it hurts, you start speaking in a different language, and then once that starts to calm down after a moment or two, then you start to feel the ache of that stub toe or that injury. So those two types of pain, fast and slow, both of them are wired into your nervous system. You're born with that wiring. It doesn't change. It is a part of you. It isn't that you have only one pathway to your brain that says, I hurt. You have two pathways. And keep in mind that there's a fast and slow pathway. So let's look at pain, how it really breaks down into your client's experience. Pain, fast pain, is typically an acute injury. It's happening what appears to be very rapidly or instantaneously. It's sharp, intense, and focused. It triggers your sympathetic nervous system. That is that if you have to, it'll tell you to run from that stimulus, that pain, or it'll tell you to tense your foot where you stubbed it, or to control the dog and try and protect yourself and fight, run, whatever it takes. Sympathetic nervous system. With that fast pain comes spikes in adrenaline, cortisol, blood sugar, adenyl triphosphate or ATP in muscle, inflammation, cytokines. Your pH in muscle drops to a more acid state. Your pain analgesic system kicks in and starts to dump endogenous opioids into your spinal cord so that you can control your pain and still run or still fight. Imagine what it would be like if something attacks you and it hurts so much that you can't fight. That is often why when someone has a trauma, then they can say, I don't even remember pain until afterward. Because you're not supposed to. If you want to survive, you don't want to. Slow pain, however, the other wiring system, typically is associated with chronic pain. And it has an achy, burning, diffuse feeling to it. That's different than sharp, intense, or focused. So that achy, burning, diffuse pain, we call slow pain. And it's generally associated with chronic. Now, fast or acute pain becomes slow pain or chronic over time if your body is able to start the healing process and control the pain levels. Chronic slow pain, if it becomes a disease process, can turn into fast or not acute, but it turns into fast or intense pain. And we see that with conditions that can range from cancer to other diseases. So keep in mind that you can move back and forth through these systems over time, but fundamentally most acute pain starts out fast and then goes to slow, and most slow or insidious conditions become chronic and they become more aching and burning and diffuse. In this system, the parasympathetic nervous system is taking over for the most part, and you have inflammation, you have pH rises instead of drops. You move more toward the alkaline so that you can heal up. Your periaqueductal gray still delivers opioids into the system to control the pain while you're healing, but it does it without turning off your pain. There's a reason for that, because that low-grade pain is a feedback loop, a signal system that stimulates your body to heal and repair. And when you're finished healing and repair, or when that system kicks on and becomes maximized during the healing process, your body goes into a state of quiescence. The PAG can cause a state of quiescence, which is a concept that means reduced motor function, relaxation, lightness, all these particular things that we'll talk about, particularly related to this approach in therapy. That is that you want your client, your patient, to arrive at that state at the end of your treatment so that you're turning on their healing processes. We encourage through this system to look at the difference between fast and slow pain when you're treating your clients. because every time you go deep and fast into a muscle and that causes that person to flinch, then you're giving them a shot of adrenaline, cortisol, blood sugar, stress hormones. And every time you can get in there slowly and work with that pain below that threshold of splinting, so that you're turning on slow, not fast pain, you're doing just the opposite. You're causing healing, growth, and repair. It's an interesting concept that throughout the rest of this presentation, it's important to keep it in the back of your mind. What is the benefit of fast and slow pain in therapy? We're going to keep pushing and encouraging you to grasp the concepts in slow pain and taking that chronic pain that your client has and converting it to a healing process. The source of pain. Pain starts at the cellular level or the nerve cell level that is called a nociceptor. Nociceptors are pain receptors throughout the body, and there's different types, many different types, but they categorically fall into typically mechanical, chemical, or temperature. There's a third type that is becoming better understood. It's called silent. The silent type of receptor is very important in its role in inflammation that we typically don't feel throughout the body. But it still is a receptor that picks up that inflammatory process. So temperature extremes, tissue damage, inflammation, and metabolic exhaustion, meaning in muscle and other systems, all trigger these nociceptors, that is, trigger pain. Nociceptors initiate pain signaling before or below the damage threshold. The purpose of that is that it's important to try and change your experience or your interface with your environment before you reach the damage threshold rather than after. But that doesn't always happen. The faster the timeline, the more likely you're going to have damage before you can change what's happening. Cartilage, visceral pleura, lung parenchyma, pericardium, central nervous system, brain, and spinal cord have zero or no nociceptors. They have no pain receptors. In a lifetime, it's estimated that approximately 70% of pain actually originates from muscle. This is very important for your profession to grasp from the point of view that if we're talking pain and we're talking 70% of most pain comes from muscle, then you are in no better place than where you are as someone who specializes in therapy for muscle to actually be a large part of the pain management process. 20% in inflammation, 5% in visceral overstretch, that is, my gut is overstretched from eating too much, from bloating, from gas, and from antibiotics in childhood that cause your nervous system to rewire and create lifelong pain from visceral overstretch. We're learning a lot about microbiomes and the problems we're having with antibiotics from an early age. But that pain associated with that experience creates visceral overstretch pain throughout adulthood. 5% connective tissue. Pain meds, pain medications typically impair healing with side effects, and that doesn't mean not to consume pain meds. It means that controlling the amount and when you take them is very important, and how much you're trying to turn off the pain is also important because of the side effects risk, and the other is that you should use pain meds in relation to sleep deficit with most injuries. That you want to control pain first so you don't get into sleep deficit, and then second so that you can still function and repair without turning pain completely off. Remember, if you turn it off completely with pain meds, then the net effect is that you don't get to experience a slow pain process after the injury or the problem, and you don't get to trigger a lot of healing responses. So in essence, pain meds typically impair healing on multiple levels. So sources of pain. 70% muscle, 10 inflammation, 5% connective, 5% visceral overstretch is a rough approximation of what we are experiencing in today's world. Muscle metabolism is very important in its role in inflammation. That is, that any time where we come out of a resting state into muscle activity, we immediately start to generate inflammation because metabolism and the contract, relax, and the whole part of using muscle generates microtrauma that has to be cleaned up and as a product of inflammation. That's normal, and our bodies are designed to handle that. But however, if we get excessive in muscle activation, that is over and above what we need for our posture, for our tone, for our the activity at hand, then it drastically drops muscle pH. And it also increases ATP and metabolic waste and glutamate. All of these components actually fire pain receptors within the muscle. So increases in tone, contractures, contractions, spasms, all of those indicate muscle activity or work to differing degrees. All of them are inflammatory, progressive inflammatory. So if we put it together and we look at where do we get a lot of our 70% of pain is from muscle, is because muscle is 80% of the body's mass. It's the largest organ, so it stands to have an immense impact on function and your experience when it becomes inflammatory or drives inflammation. So we call that inflammatory stacking, and you add it up. It's like a mathematical problem. You add muscle resting tone and activity and the neurogenic reflex over-facilitation. That is, how is your nervous system actually over-activating particular muscles or groups of muscles over and above what you need to function. You also add sympathetic nervous system activation caused by stress, anxiety, and other factors, which causes more reflexive muscle over facilitation. The more stressed I am, the more my resting tone is, the more muscle activity, the more inflammation. We then add adrenaline, blood sugar, cortisol, cholesterol, stress hormones, etc. to that equation. And then we add a very important modern addition to that mathematical equation of inflammation within muscle. And those are muscle metabolic stimulants. Sugar will activate muscle. It'll increase adrenaline in the body. It won't deliver nutrition. So excessive sugar doesn't cause extreme inflammation, but it's a part of the metabolic stacking or the inflammatory stacking. I mean, caffeine, glutamate, performance supplements, drugs, etc., can all have additional impact on muscle metabolic activity, increasing inflammation. So all of these products or these processes, from muscle overactivity, from nerve-related reflexive overactivity or facilitation, from sympathetic activation, from adrenaline, blood sugar, stress hormones, etc., to sugar, caffeine, glutamate, other things, they all equal muscle pain because they all produce compounds that trigger the pain receptors in local muscle, directly affecting the muscle's production of pain. Sources of inflammation, if we look at where does most of our inflammation come from in the body over and above normal, muscle activity, particularly overactivity. Muscle resting tone is going to contribute to some extent. Spondylogenic reflex syndromes, which is a type of nerve-related reflexive overfacilitation of multiple muscles over and above normal. Sympathetic nervous system overfacilitation of muscle again. And then muscle metabolic stimulants. This is an approximation of where we get most of our inflammation coming from or affecting the muscle process within the body. In summary, Muscle pain is the bully. It is the muscle is the big guy on the block that is pushing everything around from an inflammatory point of view. And on many other levels, from joint tracking error to joint compression and inflammation and on. It just keeps going. So muscle is 80% of the body mass again, and it has the highest rate of ATP production, or adenyl triphosphate, that comes from mitochondria within every cell. And when muscle needs more ATP to function, but when muscle is over functioning and it's starting to break down and cells are rupturing and damaging, it releases free ATP, which triggers the pain receptors within the muscle because they're ATP sensitive. It turns up, it increases the sensitivity, and it turns up the firing rate within those cells. Hence, you have more pain when you damage more muscle. So whether it's an acute bout, like in a sport or a new activity, and you have that soreness afterward, delayed onset muscle soreness, or whether it is the chronic stress, etc., and you want to ask yourself, why do my muscles ache? It's because they're producing higher rates of activity over and above normal, and that's creating an inflammatory process. So you're feeling the pain receptors from those muscles. Excess adenyl triphosphate is a signaling molecule. It's a substance for muscle pain receptors. Nociceptors are activated in tissue damage, inflammation, and fatigue. So when you damage tissue, you trigger those pain receptors because every cell releases enzymes or certain proteins, that will actually trigger the firing of those pain receptors when they rupture. Fatigue will actually generate more inflammation. So neurological referred pain is a type of pain that comes from damage or irritated structures. This is very important because neurological referred pain, trigger points fall within that category. Referred pain from a trigger point is actually from damage or irritation of structures, in this case, the muscle-fascial interface. And that structure is causing the nervous system to refer pain somewhere else. But it's not the only type of referred pain. Drops in muscle pH, increases in ATP, metabolic waste, they all are part of the inflammatory increase. Mechanical and chemical nociceptors followed by silent nociceptor activation. So many of these are mechanical and chemical processes of triggering those nerve fibers to fire and say pain. But the silent nociceptors tend to register mostly inflammatory. So when I have overactivation and inflammation in the muscles, then they trigger silent nociceptors that have a much bigger effect on the brain and nervous system in terms of you don't sense them, but they're causing long-term changes and sensitivity increases in your pain threshold. So your pain threshold drops with inflammation. The more years you have chronic inflammation, the more sensitive your pain threshold, or the lower it's going to become. Pausing for a moment, think back to what I said in the beginning. Why do we hurt so much in this country? Just remember, we're going to kind of keep talking about this and feeding it in, that inflammation is a big part of that equation. All of these directly fire local nociceptive muscle pain. Muscle is a predominant tissue for generating physical pain. What does pain look like? The following infrared images illustrate inflammation. On these images, the white is the hottest, and typically greater than 91 degrees Fahrenheit. You'll see a little temperature on each image up in the left corner, left upper. Anything above 91 degrees is a sign of inflammation. White joint zones illustrate joint inflammation. White muscle zones illustrate muscle overfacilitation and inflammation. So we're picking up both inflammation and the muscle metabolic activity through muscle overfacilitation or overfiring. The spondylogenic reflex is involved in all of these conditions, And we're looking to show you how SRT, or spinal reflex therapy, relates to these processes. This is an example of a woman pregnant with heat in her forearms and hands. If you look at the forearms, there are no joints in that area. Most of that heat is coming from muscle overactivation because the white areas overlay the muscle. If you look at the hands, there's joints in it, and you see the classic white over the thumb, base of the thumb. That's a joint inflammation. Part of the hand is joint. It's normal for the center of the palm to be a portal for more heat to escape the body. That's normal. So we see her complaint, hand pain and numbness. Concern was a Raynaud's syndrome, which is a autoimmune vascular flow problem. In this case, it was not. It was actually thoracic outlet syndrome coming from the scalene muscles in the neck, affecting nerves going into the arm, creating overactivation of those muscles and inflammation. These will make sense as we go through them. This is an example of midline spinal pain and inflammation. If we look at this, we see that the midline spinal pain and inflammation is significant, and that it is an example of pain over the joints along the center line, but when you see the flaring out from the sides, that's muscle spasms as well. This is heat accumulated in the upper back of a pro athlete at a cyclocross where you're pulling a bike up all the time. This is heat in the hamstring zone, and because that's not over a joint, then we know that it's muscle overactivation caused by spinal reflexes in the neck, actually. This is an example of plantar fasciitis, and the ability to reduce that with one 10-minute session to show you how much you can influence your body's functions from a global point of view. This is diabetic neuropathy because he had numbness and pain, but it's really looking at blood flow in the left two images compared to the right. Keep in mind that within 24 hours or so, you'll be able to access this webinar again, and you're welcome to view this. We're going through a lot of information, and we'll be going faster here in the next couple of minutes. This is an example of a person with an upper neck spondylogenic reflex, and how you can accelerate healing, by 2-3 times faster than normal. So when we're processing pain, we think fast and slow. Fast means the speed at which the nerve can carry information is extremely fast. Slow means it's extremely fast, but a little bit slower than fast. The conduction rates, it's activated by tissue trauma, inflammation, etc. And fast pain defends us, and slow pain heals us. If we take excessive pain medication and we buy into the potential illusion, or perhaps the marketing strategies, etc., to give us an idea that life is pain-free, then anytime you shoot for that zero pain threshold or a pain experience after trauma or chronic conditions, the problem is that it will start to interfere with healing pathways within the nervous system and body. The PAG is an area of the brainstem called the thalamus, and we call that a periaqueductal gray, caudal-lateral portion, and that's where pain analgesia is produced. And those are called endogenous opioids, like enkephalin and encalfins, etc. And they actually get dumped back into your spinal cord to turn off pain when you need to, whether to fight or to heal. Slow pain is what's called a C fiber, and it initiates deep, powerful, and global healing. How to control pain, the way to mitigate the cause and activate the PAG for deep healing is spinal reflex therapy and related procedures. They're safe, effective, comprehensive, swift, and without side effects. The other way to block or to mitigate, not mitigate, but to affect pain is to block pain signals and inflammation responses with pain meds. It's known to impair healing, and it can cause serious side effects in some situations. Another way to mitigate pain is surgery, and sometimes that's necessary, but it may include dismissing the causative or complicating factors leading up to that chief complaint. The root cause of most pain, we're going to tell you in this particular webinar that the spondylogenic reflex syndrome is the root cause, the SRS. What is that? It's a mechanism that whereby a spinal facet joint, the capsular ligament, gets overstretched due to tear or overstretching. It turns on your nervous system and causes overfacilitation of multiple muscles throughout the body. It lasts indefinitely or until you turn it off, either through strategies like SRT or a number of other ones related to the same approach. Until you can block that, it can go on indefinitely. And it triggers muscles to be shortened or contracted persistently throughout the body, which triggers metabolic fatigue in those muscles, which in turn triggers more inflammation. So the reactions from these spondylogenic reflexes, or SRSs, include local pain, trigger points, joint overload, joint tracking errors, muscle fibrosis over many years, muscle weakness, and all secondary reactions to those muscles and joints that basically can happen. So what is an SRS? An SRS is a defense reflex. If you can't see it, you can't hear it, you can't smell it because it's behind you, then you have receptors in your facet joints that tell you if you are getting hit or overstimulated at that level of the spine, and it kicks on muscles such as illustrated here with a left L5 facet joint. If you have a left L5 facet joint that has been injured, overstretched, or torn, it will activate these core muscles. Like a knee reflex, if I, as a physician, tap one person's knee and the rectus femoris activates and causes knee or leg extension, then if I have 100 people in my office and do the same thing, it will do the same thing in all 100 of them. Nobody will have a shoulder that gets activated and causes that shoulder to move when I tap their knee, patellar tendon reflex. If I have 7 billion people with this particular L5 level on the left side, 7 billion people will have this exact muscle pattern. This is very important because you're born with reflexes and you die with them. They don't go away, they're hardwired, and they're 100% predictable. So we're looking at this, when we look at a spondylogenic reflex, then we look at a reflex at that level where the red is on the image, that lowest vertebra on the left side, facet joint. You cannot see it, you do not hear it, you cannot stop it. It facilitates muscles plus many other cascading reactions. It becomes stuck on, it drives muscle fatigue, and it drives a pain cascade. The pain cascade looks like this. If I have that L5 that's unstable or overstretched on the left side, it will constantly turn on sclerotomal pain, myofascial trigger point pain, or dermatomal pain, or any combination. Extremity muscles aren't illustrated in these because there's a chart for every level, and these are the charts that you would actually treat in your practice. And in those timelines from 5-minute abbreviated to an hour full session. And there are extremity muscles always associated with these as well, but there's a different way to get at those because there's so many that the charts would become cumbersome, so we use just a shortcut to list those. Each link in a cascade is a source of pain. Those muscles you see on this chart can go into fatigue and cause burning and aching pain. They can jam joints in the spine and trigger nerve compression that can affect other areas. They can create myofascial trigger points in those glute fibers that can go down the back of the leg and look like sciatica, or down the side of the leg as well. The SRS pain and symptom cascade is mediated through muscle and nerve, and that one vertebra in the low back can trigger all of these type of areas of pain as secondary reactions. What is spinal reflex? It's a natural, non-invasive technique. It uses a PAG to activate healing. It's a muscle-driven PAG therapy. That is that you're able to turn on the body's healing through treating the muscles specifically related to these reflexes. Restores anatomical functionality globally, increases muscle function, range of motion, parasympathetic nervous system, stress relief, eliminates trigger points, and it delivers more pain relief and functional gains than any other technique. This is a survey of people, over 1,000 therapists and doctors who have learned this protocol, that have, in these two surveys, what we show is that with basic certification or learning, there are 7 elements that determine a successful practice. Client outcomes first. If you aren't getting a better outcome, then you're not going to get those referrals. You're not going to get that client volume to increase. You're not going to get the income without that volume. You're not going to get client overall satisfaction, professional satisfaction, or professional image and confidence are not going to follow if you don't get that client outcome. So these were increases from 6 months after completing basic certification. And then the professional, again, was, after taking professional, the same characteristics showed notable increase, particularly in important issues like referrals and volume, etc. We look at SRT as an evidence-based system, and you can click on this link or access the link with one of your handouts. 3 easy steps to immediate outcomes. You can find these in 1 minute to 2 minutes, and you can start treating, and then you can treat within that 5, 10, 30, an hour period. This is based on 80 years of formal research, 25 years of clinical application, extensive literature support, and it is evidence-based. How can I learn SRT? This is in one of your handouts, but you can register today. You can visit the SRT store. These are active links. You can go to srtmassage.com and you can find more information. You can select different training options, from a starter kit to soft tissue basic training and pro with certification and workshops. You can choose your workshop now, you can choose it later, but start learning now and start practicing now. You can use discount codes for those who are listening or watching or listening to this webinar, and you can revisit this webinar, and please share it with colleagues as well, and take some time and review and revisit, because there's a lot of information here that takes a very complicated and a huge academic area called pain management and tries to condense it into a way where you can functionally look at pain and understand it better and make a bigger difference in your clients. Thank you for attending this webinar, and please look for future webinars that will include other fascinating and powerful topics that will make a difference in your practice. I'm Dr. Frank Jarrell. Have a wonderful day.